sent you an email that had the attachment of the paper I wanted you to have for this talk. If you didn't get that, a hard copy is being passed around, and I would suggest you take a look at it. So I'm going to talk about a somewhat different topic than usual for these noontime lectures. We're going to talk about the possibility of infections as a cause of disease of unknown etiology. We'll talk a little bit about Koch's postulates and why they have been updated from what you were told in medical school, and why that is, and what the future holds in this field. It's actually a very, very interesting area in medicine at the present time. So, as you know, we live in a genomic era, and newly emerging pathogens and microbial causation of diseases of uncertain origin are now being discovered at a record pace. And the question is, are there new diseases out there, new etiologies to common diseases or uncommon diseases that we have yet to recognize? And just as an example, just think about what's happened in the last 25 years. So you may recall the Surgeon General in 1976, the United States said that all infectious diseases have been discovered, we've got treatments for them, and they're finished. So the world's going to be rid of infectious diseases. Which is a pretty bold statement, turned out to be incredibly wrong as well, because a lot of diseases that were not even thought of at the time have been recognized subsequently, and some very common diseases that were thought to be well understood, like peptic ulcer disease. You'll recall 20 years ago, 25 years ago, it was clear that peptic ulcers was a problem of excess hydrochloric acid in your stomach. You know, no acid, no ulcer was the surgical term. So there was once a time in hospitals where the hospitals were filled with patients getting vagotomy and antrectomies for their peptic ulcer disease. It's very common surgery, and we gave a bunch of antacids. And about that time, Dr. Marshall and colleagues proposed this theory that actually maybe ulcers are due to bacteria. You know, maybe it's due to Helicobacter pylori. And everybody, of course, thought the guy was crazy. And as you probably know, he now is the recipient of a Nobel Prize for his work. So diseases that we thought we understood very well, really we didn't really understand that well, and there was an underlying infectious etiology that precipitated the process. And just think again, the past 20 years, since you were born, a number of diseases have been recognized. The etiology of cash scratch disease, which was known since antiquity, but was never really figured out what the origin was until quite recently. Hepatitis C, the long-awaited non-A, non-B hepatitis. I remember when I was a resident, it was a big deal about non-A, non-B hepatitis. What was it? You know, it was important. And I remember telling patients, yes, you've got post-transfusion non-A, non-B hepatitis, but it's no big deal. It causes chronic low-grade inflammation, and you'll do fine. Little did we realize at the time that those patients, a number of them, are going to go on to develop end-stage liver disease and hepatomas, and now need liver transplants in the current millennium. So the retroviruses, the first human retroviruses that caused these in humans was recognized. Roseola, a very common viral exanthem, sometimes referred to as a sixth viral exanthem of kids, was recognized due to human herpes virus type 6. And then finally, the enigma of Jakob-Creutzfeldt disease and scrapie, this chronic wasting disease in sheep, was determined to be due to an infectious protein. And again, when Prauser first proposed this hypothesis that there was an infectious protein that didn't have a nucleic acid associated with it, he thought he was crazy as well. And of course, he's now been a recipient of a Nobel Prize for his work as well. So are there potential Nobel Prizes out there for you to discover if you're bold enough and if you have enough insight to be able to think in a slightly different way than you've been taught, perhaps, to think, that may prove to be dividends in the future. So what am I showing you? What is this picture of this person's back of his hand and thumb area, like so, with those hemorrhagic hard nodules, as you see scattered around here, and this, of course, is immediately recognizable to you as bacillary angiomatosis, right? This bacillary angiomatosis, which is a bacterial infection due to Bartonella quintana, the same organism that causes cat scratch disease in HIV-infected individuals in the West Coast. They've had an epidemic associated with this, and this is bacillary angiomatosis. And you may know, I just had to tell you briefly the story. So they had this epidemic that was occurring in the 1990s in the LA County Jail of injection drug users or HIV-infected individuals. And they break out in these very large, exuberant, nodular hemorrhagic lesions. And initially, people thought they had the gut-tape form of Kaposi sarcoma. It's not seen in but it was occurring in an epidemic, and they were having a bunch of cases all at one time. People thought that was pretty peculiar. So there was a physician who was sitting in the back of the room listening to a lecture about this, and the guy said, well, I know the diagnosis. And they said, no, you don't know the diagnosis because it's never been described before, and there's no diagnosis. He goes, no, I've seen cases of this before in the Andes Mountains in Peru. This is known as Bartonellosis or Arroyo fever or Carrier's disease, and you should look for this bacteria that's found in the skin lesions of this person's skin biopsies. And sure enough, they went back and did that and discovered that he was almost right. It was Bartonella, but there's a different species. There's Bartonella quintana rather than the Bacilliformes of Arroyo fever, but it was a very similar type idea, and turns out he was right. So, as you know, we live in a remarkable time, and things are changing. Things are changing a lot, and in the field of infectious diseases, it's a very interesting time to have your career because things really are changing. I mean, the environment's changing. The world population, as you may know, just reached 7 billion last week. So we now have 7 billion humans running around on Earth, polluting the land and usurping all its natural resources. And it's caused a lot of consternation amongst ID doctors. And additionally, it's not all bad news. I mean, if you look at what's happened in the last 50 years, from 1950 to the year 2000, a lot of major infectious diseases that we worried a lot about in the past, rheumatic fever and tuberculosis and hepatitis and measles and mumps and so on, are basically disappeared. Right? So when's the last time you saw a case of measles? I can tell you the last time you saw a case, because we saw the last case of measles in Rhode Island in 1986 in this hospital. There hasn't been a case ever since. So you probably have never seen a case of measles, but there used to be measles. There used to be mumps. There used to be a lot of things that we don't see anymore. And tuberculosis now, after a scary ride in the mid-1980s and 1990s with the AIDS epidemic, and tuberculosis is now targeted for complete removal from the American population in the next 15 years. And it may actually happen. So while we've gotten rid of a lot of infectious diseases, what's replaced them is a lot of chronic inflammatory disorders. So you've seen a lot of cases of multiple sclerosis and Crohn's disease and type 1 diabetes and asthma, which were actually pretty unusual diseases back in the early 1950s. Is now very, very common, right? The hospital's filled with them. You see these all the time when you're playing. The incidence of those inflammatory diseases are increasing. So it's out with infection, in with inflammation and malignancy as a cause of morbidity and mortality in the developed countries. It's important to point out this is in developed countries. In many developing countries, it looks more like it did in the 1950s here in the United States. What's interesting, cancer rates are increasing, of course, but they're significantly lower in farmers, garbage men, and textile workers. And you might ask, what is in common with farmers, garbage men, and textile workers? They work in a dirty environment with a lot of bacterial endotoxin in their environment. And there's reasonably good evidence that if you live in a dirty environment with lots of LPS, it promotes a Th1-like response and somebody immune-mediated response that gives you better tumor surveillance. So it's also true that smokers, I wouldn't advertise this to your patients, but smokers have a lower incidence of cancer from non-smoking related malignancies. And it's related presumably because every time you take a drag on a cigarette, you're taking a big hit of bacterial endotoxin because, of course, those tobacco leaves are not sterile. They're filled with bacteria, and they die off when they're made into cigarettes, and then the LPS is still there, and you get a nice challenge. It's been shown that these people are relatively immune to LPS-mediated events and have a better tumor surveillance than the rest of us. So the other big, a lot of things are changing. One is obesity. Obesity is like a huge problem now, right? So 1/3 of the population now in the United States is considered to be obese. Not pleasingly plump, not slightly rotund, but obese. And this is totally unknown to our population to have that degree of fat people, and it's really a problem. It's really a problem, and it's going to have a significant impact, and it's very, very interesting. The adipocytes are metabolic. They're not just sitting there holding fat globules. They're metabolically active. They're pro-inflammatory, and it turns out obesity is essentially a non-resolving inflammatory state. And you talk to these patients and ask them, why don't you lose weight? Why don't you do this? Why don't you do that? And they say, I try and I try and I can't. And they're right. They do have a hard time, and they have a tough time shaking this. The other thing that's been shown is that the endogenous microflora, if you do stool cultures of obese people versus skinny people, there's a significant difference in the microbial flora, and you can determine the weight of the patient based upon the content of their gastrointestinal tract. And there's this question now, is obesity really an epidemic? Is really a bacterial epidemic taking place? As opposed to that, yes, the people are fat, so they've got more adipose tissue, so it's changing the conditions in their gut, so they tend to get colonized with certain bacteria. So it's not clear at the present time if it's true and related, but there's a very strong association between certain bacteria and obesity. So, of course, as you know, the things are changing in our environment as well. So you wouldn't think global warming is a problem here the last few weeks in Rhode Island, but I can assure you that the world is getting warmer, and you can also debate whether it's due to fossil fuels and, Al Gore's right or the naysayers are right. I mean, those are debates which are silly in some respects, but it's very clear that the world's getting warmer. Last year, for example, was the second warmest year in world history, the warmest being 2006. So we're having a lot of really hot years, and it's changing their environment. On top of that, we've got this enormous population of people to maintain. So we've got 7 billion people on Earth. The carrying capacity of Earth, if people lived at the current rate of consumption and lifestyle of what people do in the United States, the carrying capacity of Earth would be just under 1 billion people. So we already have 7 billion people. So you can know a lot of these people living in very desperate circumstances. And in the process, they're degrading the environment like we are as well. Us, 4% of the world's population using 24% of the world's energy. It's not a sustainable situation. I mean, things are going to have to change, and things aren't changing. Things are just getting worse. And there are geopolitical reasons why that may be so, but from an infectious disease perspective, from a microbiology perspective, it's really fascinating, right? I mean, it's really interesting because we're seeing new vector-borne diseases where we hadn't seen them in a long time, new parasites where we hadn't seen them before. There are lots of reasons why that is true, but you've got a very high population, a lot of people living under subsistence conditions. Their immune systems are deficient, their housing's deficient, and they're exposed to vector-borne diseases, and things are changing. Of course, when humans are going out to cut down the rainforest, they can build roads and build farms and so on. They're changing the ecosystems and exposing human populations to disease they hadn't seen before. So it's an interesting time. And just as an example, here's the prediction of what's going to happen with malaria in the next 20 years. So malaria, for the first time in history, last year there were fewer cases of malaria in 2009, so we're a year behind, 2009 versus 2008. First time ever in human history the number of cases of malaria actually went down a little bit, which is pretty remarkable. But the thinking is that's not going to persist. It's going to go back up again, and it's going to go back with a vengeance, primarily because of global warming and climatic disruption. You know, the phrase global warming sounds to a lot of people like, that's not so bad. You know, it's going to be a little warm in the summertime, we get to spend more time at the beach, you know, the winter won't be that cold, it won't be that bad to have a little warm. But it's actually going to be a disaster, because as you know, what's happening, it's not just that things are getting a little warmer, but it produces a heated up ecosystem, which tends to cause less temperate climates and more extremes of climates. So really, really cold in the winter and really, really hot in the summertime, and more violent weather. I think you can already see that happening just in the last 10 to 15 years. And what's happening, of course, is as the duration of winters gets shorter, it allows the mosquito vectors to proliferate and do better in the northern climate. So, you know, here we are in New England. You don't worry about malaria. You know, we got a lot of things to worry about here. Malaria is generally thought not to be one. Well, it turns out that it's predicted in the next 20 years we will have to worry about malaria, because what's happening is that as the world is heating up, it's expanding the vector space, and the vectors are going to be more prominent. As you probably know, living here in Rhode Island, when you get bitten by a mosquito, we have three genera of mosquitoes here. We have Culex mosquitoes, we have Aedes mosquitoes, and we have Anopheles mosquitoes. Those Anopheles mosquitoes are the ones that transmit malaria, right? So we already have Anopheles mosquitoes, but the population is relatively low. As it gets warmer, it's going to expand, there's going to be more swamps, and it's going to increase the population of Anopheles mosquitoes, and we're going to be at greater risk for malaria. So it's anticipated that the area that's the greatest risk for a change, or increased risk of getting malaria, is actually New England. It's one of the areas, right? So the red areas, we've got a twofold greater chance of getting malaria that's anticipated in the next 20 years than other parts of the world. You can see the place where there's holoendemic malaria, things aren't going to change that much. They go up a little bit, but they already have a lot of them. But
what is green color, Doctor? What is green color?
Okay, this is the fold increased risk. So red is greater than twofold, because again, if you start from zero, one case is a 1,000% increase. The green, the green is basically things will stay the same, or maybe 1 to 5% increase, and gradations thereof. So you'll see it's primarily the Northeast and Europe, and some parts of Central Asia as well. They're going to be at increased risk for malaria. Now, I think most of us thought that the heyday for microbiology was in the latter part of the 19th century, when these two people were duking it out for microbial supremacy, Dr. Koch and Dr. Pasteur, and the Pasteur Institute against the Koch Institute, and the rather vitriolic interactions these two groups had. They were in competition with each other, and it was all tied up into geopolitical thinking and the Franco-Prussian War in the 1870s. Didn't help very much, because the French started not liking the Germans, where before the French always could care less about the Germans. You know, bunch of yahoos living in kingdoms in Prussia who cared. They didn't really care, but they cared about Britain, right? So their main enemy was the British Empire for 500 years. But they began to realize that there's these people up north, right there in their continent, they have to begin to worry about. So it turns out there was a lot of the angst between the Pasteur and Koch Institute was really political, and really was used by propaganda by both countries to say, yes, the French are better than the Germans, and vice versa when it comes to microbiology. So there was big competition. They were around trying to describe every disease you could think of. And it was a good time, and they described a lot of diseases. And we tend to give credit in the final analysis to Koch, who was thinking more like a physician because he was a physician, right? So Pasteur was a chemist and was not a physician and was interested in microbes, not that interested in microbial pathogenesis. He was aware that they can cause disease, but he actually really enjoyed understanding microorganisms. Where Koch was a physician who looked at infections as the enemy, and it was his job to eradicate those enemies. And he was very intent in trying to resolve diseases. So you'll recall that throughout the late 1800s, a lot of groups started describing pathogens with everything. So somebody had yellow fever, they would do a blood culture, they would find some bacteria, they'd say, well, that's the cause of yellow fever. And it was confusing, and so Koch decided to maybe ought to set down as some ground rules, what's actually a pathogen and what's not. And you all learned these in medical school, right? The 4 Koch's postulates. Actually, he actually posited 3 postulates. The 4th was added by unknown others later on. And I think to this day, if you ask people how important are Koch's postulates, most people would say they're sacrosanct, right? I mean, these are the fundamental basis of germ-theory disease, and they're inviolate. And so what are the postulates? Or the first postulate that he described pathogens as parasites. So his first postulate was the parasite is found in every case in which disease occurs and accounts for the disease manifestation. So the bug should be found when the disease is present and should be found in the diseased tissues. The parasite should not be found in other diseases. So in other words, if you're saying that this organism caused pneumonia, it shouldn't be found in situations where people don't have pneumonia. So if they had urinary tract infection or a skin reaction, whatever, that would tend to support that the pathogen caused pneumonia, not just hung out in the skin or was found in other parts of the body. And the third postulate, which is really the critical postulate, was that you could isolate from the individual, from the person with the disease, you could find the pathogen and grow it in artificial media and then cause the disease anew in somebody else. So usually it was experimental animals or human volunteers. So it's not easy to get people to volunteer for these experiments, but they used to be done. And they're still done today, right? I mean, you probably will, if you haven't already, you'll be offered during your residency or fellowship, gee, would you like to participate in this trial where we're going to study this, that, other thing? When I was an ID fellow, I had to roll up my sleeve and try everybody's experimental vaccine because I worked in a vaccine unit against gonorrhea and against salmonellosis and shigellosis and lots of other things. So I rolled up my sleeve all the time, took a whole bunch of shots. I didn't necessarily, and in fact, some of my friends actually volunteered for a study for malaria where they actually got experimentally infected with Gulf-Super malaria. And the vaccine didn't work, so they all wound up getting malaria. So I didn't sign up for that one. But be careful, I would tell you what you sign up for. So anyway, that was the third Koch's postulate. The fourth Koch's postulate, again, was added by other people. It's not clear who, but that was that if you had a disease, you isolate the organism, you inject it into an animal, the animal then succumbed, you should be able to re-isolate the organism and repeat the experiment over and over again, so suggesting it's actually the real pathogen. So it's true, those are very valuable, but even Koch himself realized